Welcome back to the MediByte channel. Today, we're jumping right into the medical science behind labor and delivery. Specifically, we're looking at two severe, but thankfully highly manageable complications: umbilical cord prolapse and uterine rupture. Our goal with this explainer is to give you a complete, detailed, and really easy to understand breakdown, whether you're a healthcare professional or just a curious learner. So let's get right into it. Here's a quick look at our roadmap for today. We'll start with a welcome to labor complications, explore what a cord prolapse actually is, compare overt versus occult prolapse, understand uterine rupture, and finally, walk through the emergency medical responses. Section 1. Welcome to labor complications. When we talk about labor emergencies, it's so easy for the mind to just immediately jump to panic. But here's the absolute most important thing you need to remember. These complications are highly uncommon and very, very rare. Uterine rupture, for example, it's remarkably rare. Our whole goal here at MediByte is to make sure you feel empowered by this knowledge, because truly understanding the mechanics of these rare emergencies is exactly how modern medicine manages them so incredibly well. Section 2. What is cord prolapse? Okay, let's dive into this. So, an umbilical cord prolapse happens when the cord actually precedes the baby through the vagina. Normally, of course, the baby comes first. But when that cord drops down ahead of the baby, well, we've got a mechanical emergency on our hands. As the baby moves down the birth canal, its physical body squishes that prolapsed cord right against the mother's pelvis. This literally cuts off the vital blood supply to the fetus, which, as you can imagine, demands an immediate physical solution. Section 3. Overt versus occult prolapse. Now, a prolapse doesn't always present the exact same way every time. In an overt prolapse, the condition is super obvious. The cord can literally be seen protruding into or out of the vagina, and the amniotic membranes have ruptured. We often see this in a breech presentation or if a sudden rush of amniotic fluid basically sweeps the cord out ahead of a head-first baby. Now, in total contrast, an occult prolapse is totally hidden. The membranes are intact, and you can't see the cord at all. Instead, it's trapped and compressed right next to the fetus, usually by a shoulder or the head. So if the cord is completely hidden in an occult prolapse, how do doctors even know it's happening? Well, because blood flow is restricted, it triggers a very abnormal pattern in the fetus's heart rate. By continuously monitoring that fetal heart rate during labor, healthcare professionals can spot this hidden danger right away. And honestly, amazingly, the solution is often entirely biomechanical. Simply changing the mother's position can shift the baby's weight right off the cord, relieving that compression pretty much instantly. But, of course, medicine always requires backup plans. While positional changes are incredibly effective, an occult prolapse occasionally requires an emergency cesarean delivery. If shifting doesn't relieve that pressure, doctors have to move swiftly to a C-section, just to ensure the baby's blood supply is completely protected. Section 4. Understanding uterine rupture. Let's move to this and see how it builds. A uterine rupture is exactly what it sounds like. It's a tearing open of the uterus, typically happening in late pregnancy or during active labor. In the absolute most severe cases, this tear can actually result in the fetus floating right out into the mother's abdomen. It is an incredibly dramatic, high-stakes physical event, and it demands strict, immediate emergency treatment, no questions asked. The thing is, these ruptures rarely just happen out of nowhere, without warning. They are overwhelmingly linked to prior conditions. The most prominent risk factor? A previous cesarean delivery, especially if the current labor is being artificially induced. Other risks include things like prior uterine surgeries that leave behind vulnerable scars, an overstretched uterus, maybe from excess amniotic fluid or multiple fetuses, or even mechanical stress from a doctor having to physically turn a fetus that's in the wrong position. Now, if a rupture does occur, the clinical signs are immediate and they are severe. The main symptoms to look out for are severe, constant pain in the pregnant woman's abdomen, and simultaneously, the fetus will begin to show acute signs of distress, presenting with an abnormally slow heart rate. When a medical team sees this exact combination, sudden, severe, constant pain, and a rapidly dropping fetal heart rate, their training kicks in immediately. Section 5. Emergency medical responses. Returning to the overt prolapse for a second, when the baby is pressing down on an exposed cord, the response is incredibly hands-on. A nurse or doctor will literally hold the fetus's body off the cord manually, physically keeping that vital pathway open. And they have to maintain this hold continuously while the rest of the team preps for an immediate cesarean delivery. It's a very fast-acting, highly coordinated procedure built entirely around protecting that vital blood flow. For a suspected uterine rupture, doctors need immediate visual confirmation. To get it, they perform what's called a laparotomy. It's an abdominal incision that allows the surgical team to directly view the uterus and pinpoint the exact location of the tear. Once that rupture is confirmed, the absolute first priority is getting the baby out safely via an immediate C-section. With the baby delivered safely, the focus shifts entirely to the mother, performing a surgical repair of the torn uterus. However, I should mention, if the damage is simply too severe to repair safely, a hysterectomy, which is the complete removal of the uterus, is sometimes necessary as a life-saving measure. So I want to leave you with a bit of a provocative question to think about. How does the rapid adaptability of modern medical interventions turn severe childbirth emergencies into manageable, survivable events? Seriously, think about what we've covered today. From manually lifting a fetus off a prolapsed cord to monitoring those hidden heart rate abnormalities, the structure and speed of modern medicine is nothing short of miraculous. Thank you so much for joining me on this journey through the clinical data today. If you found this explainer helpful, clear, and structured, please take a quick moment to hit that like button, share it with your colleagues, and most importantly, subscribe to the MediByte channel. Until next time, keep learning and stay curious.